side, he had gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, the mid-third fracture of a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this gallaging fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallaging fracture, and this is not reported in any literature. For such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for gallaging fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months. But this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for gallaging fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury The successful management of this double fractures case confirmed that interlocking nailing of femur and tens yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did tens. So this case was published in International Journal of Orthopedic Sciences. The registered teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike conservative management, it provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing displaced fraction of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on out the state head was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is the typical clinical presentation. A bump at the site of the fracture and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the type of cognition are the radiological indications for the surgical treatment either in the so the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are made by 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this one. Hi friends, today I will discuss more about the orthopedic implants. Just to recapitulate the whole thing that in 1939 in Turkey the KNL का आविष्कार हुआ और ये फर्स्ट वर्ल्ड वॉर में इसका उपयोग हुआ और उसके बाद 1950 में रस ब्रदर्स फ्रॉम ऑस्ट्रेलिया उन्होंने आविष्कार किया और इसको बोथ बोन फोर आर्म फ्रैक्चर में उपयोग किया गया। उसके बाद इंटरलॉकिंग का जमाना आया और इंट्रापर्टिकुलर रूप से इंटरलॉकिंग शुरू हुआ जिसे केम्प ने पॉपुलराइज किया 1970 में और उसके बाद इंट्रापर्टिकुलर रूप के बाद जो बीच में प्लेटिंग का दौर आया जिसमें शुरुआत में हेवी ड्यूटी प्लेट का यूज किया गया, फिर डायनेमिक कंप्रेशन प्लेट को यूज किया गया, फिर लो कॉन्टैक्ट डीसीपी LCDCP का यूज किया गया। उसके बाद एडवांस इंटरलॉकिंग करने जमाना आया। पहले इंटरलॉकिंग नेलिंग केवल डायफिशियल फ्रैक्चर में यूज होता था, फीमर का हो चाहे टीबिया का हो चाहे ह्यूमरस का हो, लेकिन बाद में मेटाफिशियल फ्रैक्चर के लिए भी एडवांस इंटरलॉकिंग शुरू हुआ जैसे कि लोअर एंड ऑफ द फीमर एंड upper end of the upper third of the femur, subtrochanteric fracture and supracondylar fracture के लिए DFN, supracondylar fracture के लिए DFN और subtrochanteric fracture और trochanteric fracture के लिए PFN यूज होने लगा। फिर PFN A आया ऑस्टियोपोरोटिक बोन के लिए PFN A2 आया जिसको यूज होने लगा। आजकल ये ऑस्टियोपोरोटिक बोन का ऑस्टियोपोरोटिक पेशेंट में PFN A2 ही यूज करते हैं। और मेटलर्जी के बारे में शुरू में स्टील का उपयोग हुआ जो ये तो बहुत स्टीफर होता है, about 10 times stiffer than the cortical bone of the human body. Times stiffer than the cortical bone of the human body. So ये लोड बेयरिंग हो जाता है और लोड शेयर नहीं करता है ह्यूमन बॉडी से। तो कैलस जो बनता है उसमें बीट बनता है। इसके बाद टाइटेनियम नेल्स जो नेल्स बनते हैं वो टाइटेनियम एलॉयज के बनते हैं और उसका मॉडुलस ऑफ इलास्टिसिटी ऑलमोस्ट सिमिलर होता है कॉर्टिकल बोन के मॉडुलस ऑफ इलास्टिसिटी के बराबर होता है, ऑलमोस्ट सिमिलर होता है। इस तरह से उसको एलॉय बनाया जाता है, इस तरह से मॉडिफाई किया जाता है। सो इट इज मोर बायो फ्रेंडली एंड बायो कंफर्टेबल। उसके बाद आया कार्बन फाइबर्स का, जो कार्बन फाइबर्स का because it is translucent, it is not radio opaque, so it is very useful in cancer patient, pathological fracture due to bone tumor, उसमें क्या प्रोग्रेस है ट्यूमर का, जो ट्रीटमेंट दिया जा रहा है उससे रिग्रेशन हो रहा है कि नहीं, चारों तरफ ट्यूमर के हम लोग देख सकते हैं और फ्रैक्चर का कैलस बन रहा है कि नहीं ये भी देख सकते हैं क्योंकि ये रेडियो ट्रांसमिशन होता है, रेडियो ओपेक नहीं होता है और कोल्ड वेडिंग नहीं होता है। सबसे बड़ा एडवांटेज ये स्क्रू को निकालना जो है आसान है और काफी जो बहुत हाई फैटिक स्ट्रेंथ होता है इसका, जो काफी ड्यूरेबल होता है और फ्रैक्चर हीलिंग तक ये टूटता नहीं है, इसमें कोरोजन नहीं होता है और कार्बन फाइबर्स में कोरोजन नहीं होता है और कैंसर पेशेंट में यूजफुल है और स्ट्रेस से भी नहीं होता है, जो कि मेटल में होता है, और वीक कैलस बनता है। इसमें काफी स्ट्रॉन्ग कैलस बनता है। इसका डिसएडवांटेज ये है कि इसको बेंड नहीं किया जा सकता। ऑपरेशन के समय हम लोग प्लेट को बेंड करते हैं ताकि बोन का शेप ले ले, वो मैनुअली बेंड करते हैं, तो उसको आप बेंड नहीं कर सकते हैं। ये टूट जाता है लेकिन बेंड नहीं होता है। सो थैंक यू। हेलो फ्रेंड्स, I am Dr. R.C. Thakur, orthopedic surgeon, Chhapra, Bihar.